glottis and the cricoid. These three are unpaired, and the remaining three will be actually the paired one, that is arytenoid, cuneiform and corniculate. So arytenoid, cuneiform and corniculate, all these three will be paired except the thyroid. Thyroid will be the unpaired one, guys. And remember, thyroid cartilage is actually one of the example of your hyaline cartilage only, right? Yes, so keep that thing also in mind, the type of cartilage is over there. Then the next question here, guys. Which of the following is the abductor of vocal cords? Abductor of the vocal cord. Now please look at this diagram here. Now in this diagram, you are able to see here this muscle. This muscle is actually the posterior cricoarytenoid muscle. Posterior cricoarytenoid muscle, guys. It is between the arytenoid cartilage and the cricoid cartilage. So cricoarytenoid muscle, and this one here will be the lateral cricoarytenoid muscle. Lateral cricoarytenoid muscle, guys. And in this, the best way to remember is with the direction. Now, for example, if this muscle will contract, the posterior cricoarytenoid muscle will contract, then what is going to happen? If the muscle will contract, it is going to take this vocal cords away from here, sir. Vocal cords away from here. So that is the abductor of the vocal cords. That is the only abductor of the vocal cords, important one. And apart from that, because it is able to abduct the vocal cords, then it is going to keep the airway patent. The airway will remain like open, patent. So that is the reason why it is also known as the safety muscle of the larynx. So both of these questions has been asked in your exam. Take care about that one here. So which of the following is the abductor of the vocal cord here? That is the posterior cricoarytenoid. Posterior cricoarytenoid. So basically my intention here is that, my main intention here is that, okay, like you have to remember, please make a note, like wherever you're writing, you have to recall or revise about the larynx topic, guys. About the muscles of the larynx and about the actions of the muscles as well as the cartilages and all. Next one. Which of the following is true except which one, guys? Now, when it comes to neuroanatomy, I'll tell you one thing, your entire exam, your FMGE exam will not be completed without a section from the brain, sir. Brain, yes, all the three sections, definitely they'll be tested in your exam, whether it is sagittal section or the coronal section or the transverse section of the brain. So before your FMGE exam, you have to be like perfect with all the three sections, and you should be able to identify everything over there in those sections. Is it okay? So now, before discussing about this question, let us see the coronal section of the brain here itself, guys. So I want you all to become perfect in the coronal section here. Now in this coronal section, yes, first of all, you are able to see here there is a lateral ventricle here, and then there is a lateral ventricle here. And these two lateral ventricles are separated with the help of septum in the middle, and that septum will be the septum pellucidum. Now these two lateral ventricles will actually lead into the third ventricle, guys. The two lateral ventricles will be actually leading into the third ventricle via foramen of Monro. Now first thing is, the two cerebral hemispheres are connected with the help of band of fibers. That is nothing but the white matter. Now remember, this bundle of fibers here, with this bundle of white matter over here, is actually nothing but your corpus callosum. Corpus callosum. Okay. So the bundle of axons, the white matter connecting the right and left half, will be commissural fiber, and out of that the largest commissural fiber will be the corpus callosum. So first you should be able to identify the corpus callosum there. And not only that, the corpus callosum is also going to form the roof of the lateral ventricle, guys. The corpus callosum is going to form what, guys? The roof of the lateral ventricle. Now between the two lateral ventricles there is a septum in the middle, and this septum is known as septum pellucidum. And the most important thing is, if this is your septum pellucidum, for example, if my hand is like septum pellucidum here, yes, just beneath that, the lower border will be attached to the fornix, and that has been tested a lot of times. So please keep in mind here, the septum in the middle is known as the septum pellucidum, and the lower border of that will be attached to what, guys? The fornix here. So in the middle you will be having septum pellucidum, and the lower border is attached with fornix. And this is actually going to form the medial wall of the lateral ventricle. Lateral ventricle medial wall is formed by the septum pellucidum as well as fornix. Now, apart from that, the floor is actually very much important, guys. The floor is important for every ventricle, whether it is like little ventricle or third ventricle or fourth ventricle. So, floor आपको ना अच्छे से पढ़ना बहुत ज़रूरी है. Now, in this diagram, first, this will be the caudate nucleus, the head of the caudate nucleus, and below that here, this will be the thalamus part, the caudate nucleus and the thalamus. In between them, you will be able to appreciate, yes, there will be a vein that will be the thalamostriate vein. Thalamostriate vein will be appreciated in between them, sir. So, there is a caudate nucleus and the thalamus, and yes, there will be a vein present here, that is the thalamostriate vein, guys. Now, apart from that, if you are able to see here in this diagram, you will be able to see that there will be a network of capillaries, and that is known as the choroid plexus. So, all these four structures, that is your caudate nucleus, the thalamostriate vein, and the choroid plexus, are going to form the floor of the lateral ventricle. Now why I am actually teaching you this one here? Now, why I am actually teaching you this one here? In one of your FMGE exam, they have already asked in the image-based question about the lentiform nucleus. There will be a lentiform nucleus here. So, there will be a caudate nucleus, and then there will be a thalamus here, and then there will be a lentiform nucleus here, guys. Fine here? The caudate nucleus, the thalamus, and the lentiform nucleus here, guys. Okay. Now, between them, you are able to appreciate here, this is the white matter present here, and this white matter here is nothing but your internal capsule. That's your internal capsule, guys. So, you should be able to identify all these structures in the coronal section of the brain. So, that is, as I told you, in the brain, yes, out of the 3 sections, definitely one section will be asked. Without that, the exam paper will not be completed. So, that is why you have to know this section here, and you should be able to identify all the structures. Now, after seeing all these structures over here, welcome back, my dear friends. Now, in this diagram, I hope you are able to see here, A is actually the caudate nucleus, absolutely correct. And this B here, it is actually thalamus, that is also absolutely correct. And the C here will be the lentiform nucleus, that is also absolutely correct. But D is not internal capsule, it is actually external capsule. Why? Because internal capsule is somewhere over here. So, that's actually external capsule, guys. Lentiform nucleus is actually given the name as lentiform. Okay. Why? Because yes, it is lens shaped, and because this lentiform nucleus is like lens shaped here, there will be a capsule inside, internal capsule, and there will be a capsule outside, that is your external capsule. Is it okay? So, therefore, that fourth option is wrong. By the way, it's not about this question here, it's all about the concept here, guys. I want you to remember about the coronal section, and I told you about all the structures in the coronal section here. Hope you are able to identify them, guys. Done. Now, apart from that, now let us go to the next question. Now, this next question I kept here in sequence. Why? Because yes, this was the exact question that was given in your exam. This was the question that was actually given in your exam there, guys. Yes, there was a radiological image, and in that radiological image, yes, they have asked you to identify about the lentiform nucleus. So, I hope you will be able to identify this one here in this one. Now, the next ones, guys. Benzodiazepine is actually asking about the internal capsule location. See, benzodiazepine, I don't know why people hide their names. Internal capsule is exactly located between the lentiform nucleus towards the lateral side. Lentiform nucleus will be towards the lateral side, and the caudate nucleus and thalamus will be towards the medial side, sir. So, internal capsule is between the lentiform nucleus and then the caudate and the thalamus on the medial side. Is it okay? Perfectly. That is the exact location of the internal capsule. Next one. Now, after this, yes, this is the question that was given in your MCA exam. You should be able to identify the lentiform nucleus in this one here, sir. Now, after that, let us go towards the next question here. Okay. So, later on, actually, I'll tell you about the other sections of the brain also. Okay, now we have discussed about the coronal section in detail. I hope this is helpful for you guys. Okay, na? Next one. Now, injury to bulbar urethra leads to extravasation of urine in all except. This can even come like a clinical question also, guys. Even though I have given you very simple here, injury to bulbar urethra leads to extravasation of urine in all except. I have just given you like a one-liner here. The same thing we can actually make it like a clinical question. Tomorrow in the exam they can ask you a clinical question. A person walking on the road suddenly falls down into the into the manhole, and then he gets hit in the perineum region, and because of that the bulbar urethra is damaged. Similarly, like a person sitting on the bicycle and riding on the bumpy roads. So on the bicycle and riding on the bumpy roads, at that time again they'll be hit in the perineum region and all. So they can just make a frame a question, a male aged about 20 years riding a bicycle on a bumpy road hits in the perineum region and bulbar urethra will be damaged, something like that. So instead of just this one liner, the same thing question can come as a clinical question also, which is like very much like trending nowadays, guys. By the way, let me actually tell you the concept here, guys. What is this bulbar urethra? If it is damaged, then what is going to happen? Where will the urine going? Okay, exactly. Now, please look at this image on your screen. This is actually the male pelvis in sagittal section. The male pelvis in sagittal section, sir. Now, in this diagram, first you are able to appreciate here that this one here will be the superior fascia of a urogenital diaphragm. I hope at this point of time when the exam is very much nearby, you all know very well what is a urogenital diaphragm. I have taught that very clearly, yes, in the videos, in our doctoral videos and all. So, urogenital diaphragm and pelvic diaphragm, most of the students will not have a clarity. Please remember that this is nothing but the urogenital diaphragm over here, so this one, okay. Now, this urogenital diaphragm, it will be having like two fascia, one fascia above, that is the superior fascia of the urogenital diaphragm, and then there will be inferior fascia of urogenital diaphragm. There will be superior fascia and then there will be inferior fascia of urogenital diaphragm. Then apart from that, yes, remember in the perineum region that there will be a fascia, and this fascia is nothing but the superficial fascia. Be very careful with the naming here. It's not superior, it's actually superficial fascia. It's not superior, it's actually superficial fascia, which is also known as the Colles fascia. Colles fascia bhi kehte hain, sir. So better what you do is, you just keep it like very simple in your mind instead of getting confused here. Keep it like very, very simple in your minds here, guys. There will be a superior fascia, and then there will be inferior fascia, and then there will be superficial fascia. Let me write it for you here. This is the superior fascia of a urogenital diaphragm. This here will be the inferior fascia of a urogenital diaphragm, and this one here will be the superficial fascia of perineum region, and which is also known as the Colles fascia also, guys. Isko na Colles fascia bhi kehte hain. So now if you just keep it like simple 3 lines here, yes, the concept becomes so simple here, guys. Remember, agar aap ye 3 line yaad rakhoge na, if you're having like 3 fascia, how many pouches do you have in the middle? You'll be having only like 2 pouches there, and the naming of these pouches will be given superficially, hai na? So this one here will be the superficial perineal pouch, and this one here will be the deep perineal pouch. So there'll be like 3 fascia, and out of that 3 fascia, in between the 3 fascia, you'll be actually having like 2 pouches here, sir. One is the superficial perineal pouch, another one is the deep perineal pouch, sir. Okay? So it's so simple. Unnecessarily don't confuse yourself, guys. Now, welcome here. Now, in this, I hope you all know that the male urethra, which is approximately 20 centimeters long, the male urethra is actually divided into 3 parts. The one which you are able to see here, passing through the prostate gland, this one is the prostatic urethra, and then this small urethra here, that is actually the membranous urethra, and the remaining, this one here, it will be actually the penile urethra. To be more specific, it is in the bulbar part of the penis, bulb of the penis, so therefore it is bulbar urethra. Okay? So that is prostatic urethra, then membranous urethra, and the bulbar urethra, sir. Prostatic urethra, membranous urethra, and bulbar urethra. Fine. Now, suppose if this bulbar urethra is damaged, according to our question, yes, in the clinical question, either the person, falling in the manhole, or suppose there is a injury while, riding a bicycle, he gets a hit in the perineum region here. And once he gets a hit here, then what is going to happen here, guys? The bulbar urethra will be damaged. If this bulbar urethra is damaged here, then what is going to happen? The urine will extravasate out. The urine will go out. The urine will go out into the superficial perineal pouch. Apart from that, the urine will also go into the thigh also. Because that same fascia will continue down also, guys. Apart from that, the urine will also go into the scrotal sac or scrotum. And not only that, the urine will also extravasate out into the anterior abdominal wall. The urine will also extravasate out into the anterior abdominal wall, guys. So you can clearly see here in the diagram, the fascia is actually continuous there. So the urine will extravasate out into the superficial perineal pouch, into the thigh, into the scrotum, as well as the anterior abdominal wall. Fine. Now once you have understood this concept over here, yes, welcome back to our question, guys. Injury to bulbar urethra leads to extravasation of urine in superficial perineal pouch, into the scrotum, into the thigh, but not into the deep perineal pouch. Not into the deep perineal pouch. And just to complete this option here also, guys, yes, deep perineal pouch में कैसे extravasate होगा? If there is an injury to the membranous urethra, if this membranous urethra is damaged here, not the bulbar, if the membranous urethra is damaged here, then the urine will extravasate out into the deep perineal pouch. The urine will extravasate out into the deep perineal pouch, guys. Fine. So I hope the concept is very clear now. So one of the clinical condition we have discussed here, guys, that is extravasation of urine. The urine is going out if there is a rupture of bulbar urethra or the membranous urethra. So I hope it is very clear for my students. Or do I have to repeat this one? I think the concept is very simple. No? Don't complicate that. Most of the time what will happen, pelvis and perineum topic, most of the students will not be studying properly. So they'll not have a clarity in the concept there, guys. So it's very simple. Keep it like simple, neat and clear, guys. Done. Now once this is done here, let us go to the next concept. Yes, one of the hot favorite concept of MC examiner. Nowadays they're asking a lot about the axillary artery and the branches of axillary artery. So I have given you a question here. You have to identify the branches here, guys. And last year what happened? Not only the textbook image and not even the cadaveric image. In the exam they have given the hand drawn diagram of axillary artery. Hand drawn diagram of axillary artery. So axillary artery, neither this textbook diagram was given nor the cadaveric image was given. It was actually a hand drawn diagram which was given like last year. So thank God, always I'm having a habit of making the students draw the diagram in the class as well as in our DocTutorials app also. I will actually make the students actually draw the diagram with me. So that has helped my students. Thank God, our hard work has paid off, है ना? तो हम क्या करते हैं ना, first of all we'll try to see in this diagram, and then you also at the last moment here, just few days before the exam, once you draw that, so that it will at least remain in your temporary memory, guys, है ना? Thank you everyone. Now my dear friends, look at this diagram here. Now in this diagram, this is actually the first rib here, and this will be the outer border of the first rib, sir. And from the outer border of the first rib begins your axillary artery, and that is going to be up to the lower border of teres major. So axillary artery is extending from where to where? The outer border of the first rib up to the lower border of teres major. Okay? Yes. After that, my dear friends, look here. This is the rib number 3 here, and the rib number 4 here, and rib number 5. And from here there is a muscle going to begin, and that muscle will be the pectoralis minor muscle. Pectoralis minor muscle, guys. And that pectoralis minor muscle will go and get inserted onto the coracoid process. Coracoid process. Now, Because of that pectoralis minor muscle, the entire axillary artery will be divided into 3 parts. The part which is present before the muscle se pehle, that is the first part of the artery. The part which is present behind the muscle ke piche, that is the second part of the artery. And the part present after the muscle, that is the third part of the artery, guys. Third part of the artery. So, one question which is possible here is that, yes, one question which is possible here is that axillary artery is divided into how many parts? 3 parts. By which muscle? That is your pectoralis minor muscle. So, pectoralis minor muscle will divide the entire axillary artery into how many parts? 3 parts में divide करता है. Now this will actually have branches, and there is a beautiful symmetry here. The first part will give 1 branch, the second part will give 2 branches, and the third part will actually give like 3 branches here. Now what are these branches? Let me first of all tell you with the help of our diagram here, and I request all of you to please at least on a rough paper and pen, you are writing the topics as well as please draw a diagram there, guys. Just make a note of all the topics whichever I am telling you in our expected question series here. Make a note of that and please try to draw the diagram, guys, in the last moment. God knows it might actually come in the exam and it might help you actually. So now for example, if this is the axillary artery here, from the outer border of the first rib up to the lower border of teres major, this is the axillary artery, and this is the coracoid process here. And then what is going to happen here is that ये वाला आपका होगा pectoralis minor muscle. So as I told you, before the muscle, this is the first part, behind the muscle it is second part, and after the muscle it is actually the third part, sir. First part will give only 1 branch, and this one will be superior thoracic artery. That is superior thoracic artery. It's very simple. This is our thorax, and first part is just here above the thorax, superior thoracic artery. Second part will give 2 branches. Please be very careful how to identify in the exam. I'm telling you in the image based question. अगर आपको image based question दिया जाएगा exam में, आप कैसे पहचानोगे? This branch is present towards the lateral border of pectoralis minor. Lateral border of pectoralis minor. Lateral border of pectoralis minor. And that is actually the lateral thoracic artery. Lateral thoracic artery. Apart from that, one more branch is given here, and this branch is going towards here, guys, and that is thoracoacromial artery. Thoracoacromial artery. That is how you have to identify. So second part will give like 2 branches. One will be the lateral thoracic artery, another one will be the thoracoacromial artery. Very simple. And third part will give 3 branches. ये तो और भी आसान है. It's much more simple. Now the third part, what is going to happen? It is nearby your humerus bone here. And because there is a humerus bone there, one of the branch is going in front of that, taking a turn like this here, guys. Another branch is going behind this one here, sir. So what is the name of this branch here? That is your circumflex artery. Any artery which is going around circumflex, and it is going around the humerus, circumflex humeral artery. So there will be one anterior circumflex humeral artery, there will be one posterior circumflex humeral artery. It is going around the humerus here. And the third branch will be actually going down below the scapula. So therefore, this one here will be the subscapular artery. That is subscapular artery, guys. So I repeat once more here, the first part will give only 1 branch, that is superior thoracic artery. Second part will give 2 branches, lateral thoracic artery and thoracoacromial artery. And the third part will give 3 branches, anterior and the posterior circumflex humeral artery and subscapular. And whatever feedback I got from your seniors in the last year, they have asked the question regarding axillary artery, and in this axillary artery they have given the hand drawn diagram exactly like this. Okay, and in this hand drawn diagram they have asked the name of these branches sequentially. Like for example, they have given like something like number 1 here, and this one was number 2 here, and this one was number 3 here, and they have asked the name of these 3 branches in the options. Sequentially you have to answer like which is the first one, second one, the third one, guys. So the first one here is superior thoracic artery, let's try. And the second one here is the lateral thoracic artery. And the third one here will be the subscapular artery. I hope you're getting, my dear friends. So nowadays, slowly what is going to happen, the standard of exam is increasing. So better always, follow like whatever the faculties are actually teaching you in the classes and whatever high yield topics are there, because the standard is increasing here. So you have to follow this one here. So this is another important topic, another important concept which I wanted to discuss with you guys. Now moving on to the next concept after axillary artery. Another hot favorite thing and a very old question and very important one also. corticospinal tract is crossing at which level? First of all, I hope you all know this corticospinal tract with another name, the very famous name of this one, that is the pyramidal tract. Corticospinal tract, it is also known as what, guys? Pyramidal tract. And pyramidal tract, it is one of the descending tract. It is a motor tract and a descending tract. And it's going to descend down from the cerebral hemisphere, the diencephalon, the midbrain, and finally, in the medulla oblongata, it is going to cross. Okay. In the medulla oblongata, yes, what is going to happen, guys? The corticospinal tract is going to cross. The 90% of the fibers are going to cross. So therefore, it is crossing in the medulla oblongata. But अगर आप options देखोगे, there is one upper medulla and the lower medulla. So remember, the corticospinal tract is going to cross in the lower medulla. This is one of the hot favorite question asked repeatedly in your MC exam. So that is the reason why I have just included one simple question here, so that you at least revise that before the exam, sir. Before the exam, at least आप उसको एक बार ना revise कर लो कि pyramidal tract crossing पूछा जाता है. And instead of giving this word as crosses, they can even ask you pyramidal decussation also. The crossing is known as pyramidal decussation. So pyramidal decussation, the crossing will take place at the lower medulla. Lower medulla में ये ना crossing होती है, sir. ठीक है? Next one, sir. Next one. Yes, this was given in the last year exam. This image-based question was given in the last year exam. One thing I would like to tell you here, nowadays, as you all know, guys, most of the clinical questions are being asked in the exam. Along with the clinical question, integrated questions are being asked. And in integrated questions, what is going to happen? Yes, of course, anatomy is very well integrated with orthopedics. Anatomy is very well integrated with surgery and other subjects like ENT, opthal, everywhere. And apart from that, yes, anatomy is very well integrated with radiology. So what is the kind of trend I am seeing from last 2 years? Be ready for that one, is that they are giving the images in the form of radiological image only, but the question is mostly anatomical question. Okay. So image is actually given as a radiological image, but the question is mainly what, guys? Anatomical image. So please, my dear friends, I would request all of you to remember that you have to study all the subjects. सारे subjects पढ़ना बहुत ज़रूरी है, because integration में like they can ask you from any subject. So that is the reason why. Remember, all you have to study like all the subjects here. Now, what is the artery involved in the hematoma shown in the given image? Now, in the given image is nothing but your EDH. I hope you are able to identify it very easily there, guys. EDH, epidural hemorrhage or extradural hemorrhage. So this is the epidural hemorrhage or extradural hemorrhage here. Fine. And yes, idli shaped. There are like various names to remember for that one. Very good, Dipesh Soni. Idli shaped, or the biconvex shape, lens shaped, something like that. And in EDH, in epidural hemorrhage, the artery that is actually involved, the artery involved in the epidural hemorrhage will be the middle meningeal artery. It is middle meningeal artery. Yes. Yes, of course, I'm really happy with Jitesh Kumar also, middle meningeal artery, which is a branch of maxillary artery. Yes, of course. So, middle meningeal artery, and remember one more thing here itself, that middle meningeal artery is going to pass through a foramen, and that foramen will be the foramen spinosum. We have discussed this one in head and neck topic about all the cranial foramens, and there will be a foramen known as the cranial, that is your foramen spinosum, and through the foramen spinosum, what is going to happen? Middle meningeal artery is going to pass. And suppose if there is a hit or any trauma in the temporal region over here, then what will happen? The middle meningeal artery will be ruptured, leading to epidural hemorrhage. So I do have a comparative image here, guys. So in epidural hemorrhage, what is going to happen? The middle meningeal artery will be ruptured there. Whereas in subdural hemorrhage, what is going to happen? The bridging veins are going to rupture there, guys. And simultaneously, you will be also having the radiological image along with this one. Now, moving on to the next concept here. The next concept is, given congenital anomaly is due to defect in. Again, as I said you, the image was actually given as a radiological image, and you have to identify this congenital anomaly. So, before I teach you, can anyone just look at this radiology image here and tell me like what is this anomaly, guys? Yes, everyone here. First of all, tell me like what is this anomaly here? Can anyone answer me here? Yes, very good guys, very good. I'm really happy. Very good Dipesh, Soni, very good Prashant. Actually, the image is actually showing you the congenital diaphragmatic hernia. Congenital diaphragmatic hernia. Okay. Now, in this congenital diaphragmatic hernia, it's due to what? Like, what is the reason for this one? To understand the reason for this one, first of all, you should know what will be the normal development of, yes, abdominal viscera is actually going into that one. Yes, very good, very good. So what is the normal development of the diaphragm? वो हम पढ़ेंगे ना सबसे पहले ना. So in anatomy, let me first of all tell you about the development of diaphragm. Remember, whenever you learn about development of diaphragm is actually formed by 4 structures. One is septum transversum, another one is the pleuroperitoneal membrane, another one will be the dorsal mesoesophagus as well as the cervical somites. ठीक है ना? Now, for example, if you are looking at this diaphragm, guys, developing diaphragm from above, है ना? Our diaphragm is like dome shaped, and this developing diaphragm we are seeing from above. अगर हम ऊपर से देख रहे हैं, तो first you'll be actually having a septum here, and this septum here will be known as the septum transversum. That is septum transversum, and septum transversum is mainly going to form the central tendon. Diaphragm is dome shaped. They'll be having a central tendon along with the muscular part, musculotendinous structure there, guys. So central tendon is formed by the septum transversum. Then you also have the esophagus here, and then this structure which is coming from the dorsal side and encircling this one here. This one is referred to as the dorsal mesoesophagus. Dorsal mesoesophagus, guys. And then apart from that, the body wall, the muscular part, muscle part should be actually formed from somites. And remember, this is the place where most of the students will be confused. This will be derived from the cervical somites. Now, why I am telling you students will be confused here, all the foreign medical graduates will be confused here. Why? Because here diaphragm तो यहाँ होता है. Diaphragm is actually present between the thorax and the abdomen here. है ना? But how come the cervical somites contributing to the muscle here? So I will tell you one simple method to remember this one. Don't get confused with this word cervical. I have seen like many students in the exam. They'll be like very much confident कि cervical तो हो ही नहीं सकता है. Cervical is not at all possible. Why? Because diaphragm is here and cervical neck is over here. Remember one thing, diaphragm is supplied by phrenic nerve. I'll tell you the trick how to remember that one without any confusion. Diaphragm will be supplied by the phrenic nerve, and phrenic nerve, what is the root value? What is the root value of the phrenic nerve, guys? It is actually C3, C4 and C5. So phrenic nerve is actually coming from here, C3, C4 and C5, and after beginning from here it is passing through the neck region and through the mediastinum and finally going and supplying to diaphragm here. Is it okay? So remember with this one, phrenic nerve is coming from the cervical region. So cervical somites are the one which are contributing for the muscle wala part of the diaphragm. And whatever is left out here, this is the pleuroperitoneal membrane. Above you'll be having the pleura, below the peritoneum, the pleuroperitoneal membrane, guys. So this one here will be the pleuroperitoneal membrane, and this one here will be another pleuroperitoneal membrane. They'll be paired here. Is it okay? So septum transversum, the cervical somites, as well as the dorsal mesoesophagus and pleuroperitoneal membrane. So I told you the normal development of the diaphragm. Diaphragm ka normal development ho gaya. It is from all these 4 structures. Now, what is the anomaly here, guys? What is the problem? Yes, this pleuroperitoneal membrane, agar ye form nahi hoga, if it is not at all formed, if it is absent, then what is going to happen? Yes, it will lead to congenital diaphragmatic hernia. So the given congenital anomaly is nothing but congenital diaphragmatic hernia, and this is due to the absence of pleuroperitoneal membrane. Pleuroperitoneal membrane. And during development, what is going to happen? The abdominal pressure more, and because abdominal pressure is more, all the abdominal viscera are actually herniating into the, yes, the the thoracic cavity over there, and then they're actually going to compress the lungs, all those things. So this picture gives you a very clear idea about the congenital diaphragmatic hernia, guys. The same thing is being showed in your exam as the radiological image over here. I hope this concept is extremely clear, crystal clear concept, guys. So because this was already given in your MCA exam, so this is very much important, guys. That is why I have explained you the entire thing, the development of diaphragm from all the 4 structures, which structure is going to form where is the confusion is the cervical somites over here, and then the application part of that one. So agar pleuroperitoneal membrane absent hoga, if it is absent there, then it will lead to what's a congenital diaphragmatic hernia. Next one. Now, as I told you that there are like so many questions being asked in the last 2 years, 2-3 years from the larynx and pharynx, guys. Okay, constantly they're asking. So one question from the pharynx part also, guys. Let us see the pharynx wala part. The Killian's dehiscence is seen between what, guys? Killian's dehiscence is actually a triangle shaped like weak area in the pharyngeal wall. So let us see it is between like which muscles. So to understand that, I request all of you to please look at this diagram. So pharyngeal wall, you all know very well, our pharyngeal, the wall of the pharynx is actually muscular and fibromuscular. So it will have like longitudinal muscles also as well as circular muscles, guys. When it comes to circular muscles, circular muscles are actually the constrictor muscles. So you have got the superior constrictor muscle. So this one is the superior constrictor muscle over here. And this here will be the middle constrictor muscle over here. And this below here, this one will be the inferior constrictor muscle here. But now this inferior constrictor muscle in turn has got like 2 parts. Number one, you are able to appreciate here, this is the thyroid cartilage, and from the thyroid cartilage, these oblique fibers which are going to the pharyngeal raphe behind, these oblique fibers, that is nothing but thyropharyngeus muscle. This is thyropharyngeus muscle, guys. Okay. And below here there will be cricoid cartilage, and this one will be the cricopharyngeus muscle. Remember the thyropharyngeus as well as the cricopharyngeus. Thyropharyngeus as well as the cricopharyngeus, these two will be a part of your inferior constrictor only. Inferior constrictor has got like 2 types of fibers there. So these together nothing but inferior constrictor. Now what is going to happen is between the thyropharyngeus and cricopharyngeus, there will be a triangle shaped weak area here, sir. There will be a triangular shaped weak area here. You can more clearly appreciate that from behind when you see the pharyngeal wall from behind. So that is actually, that weak area is nothing but your Killian's dehiscence, and whenever the pressure in the pharynx will be more, and in the elderly people, normally what will happen as the age increases, the things are going to become like very much weaker. So the pharyngeal wall also become very much weak in the elderly people, and suddenly suppose if there is increased pressure in the pharynx, then what is going to happen? From this wall there will be a projection, there will be a diverticulum, that is known as what, guys? The Zenker's diverticulum. So that weak area, there is nothing but Killian's dehiscence, and the diverticulum that is going to come out from here, the outpouching, that is nothing but the Zenker's diverticulum which is going to outpouch from here, guys. Okay. So going back to our question here, the Killian's dehiscence is actually between which 2 muscles here? One will be the thyropharyngeus and the cricopharyngeus, guys. Thyropharyngeus and the cricopharyngeus. Remember this one here. Okay. Next one, guys. Thank you, Sumit. So that is one important concept that you have to remember. Now the next one. This question has been repeated like 2 to 3 times in your exam about the winging of scapula. The nerve involved in the given condition is nothing but the the given condition. The moment you look at the diagram there, you can easily appreciate, yes sir, it is winging of scapula. And winging of scapula, yes, what is the nerve involved? It is the long thoracic nerve involved, guys. Long thoracic nerve which is involved, and this is the nerve which is coming from your C5, C6 and C7, guys. Okay. So winging of scapula, the long thoracic nerve is involved, and this nerve will be actually supplying to a muscle. That muscle is nothing but your serratus anterior muscle, guys. Nerve to serratus anterior, or else it is also known as what, guys? Nerve of Bell. So the long thoracic nerve which is also supplying to is serratus anterior muscle. Serratus anterior muscle will be Serratus anterior muscle will be attached to the upper 8 ribs, guys. And when this muscle is going to contract, what is going to happen? It is helping in punching and pushing movements. It is helping in punching and pushing movement, guys. So that is the reason why serratus anterior muscle is also known as boxer's muscle. उसको हम boxer's muscle भी कहते हैं. Now, right now, suppose wherever you are sitting right now, guys, wherever you are, in whatever corner of the world you are right now, suppose right now, if you and me, we are like normal people, if we push, अगर हम इसको push करेंगे, ऐसे ना, if you're going to push against something, then what is going to happen? Our back will be absolutely normal. When you're going to push something, our back will be normal. But suppose if this long thoracic nerve is injured, the serratus anterior muscle is paralyzed. If this muscle is paralyzed, then what is going to happen? Ask that patient to push. When he's trying to push, what is going to happen, guys? Yes, this scapula will become like more prominent. The scapula bone will become more prominent. And if you want to remember the medial border of the scapula becomes like more prominent. So to be more specific, the medial border of the scapula becomes more prominent in winging of scapula. So what is a nerve? What is the nerve damage here? The long thoracic nerve. And then what is the muscle which is paralyzed here, sir? That is nothing but the serratus anterior muscle which is paralyzed here. Okay. Now, saying this, I want you to remember like few things here, guys. This is the diagram of your brachial plexus. I hope you all are like expert in the brachial plexus. I know. Now at this last moment, just before the exam, I don't have to teach you all these basics and all. So brachial plexus तो आपको अच्छे से पता ही होगा. So number one, the brachial plexus will be having roots here, and then the roots will actually combine to form the trunk. There will be 3 trunks: upper trunk, middle trunk, and lower trunk. And then trunks will divide into what, guys? Divisions, and divisions will combine to form the cords, and cords will finally give you what? Branches. There are like 5 parts in the brachial plexus. Now in this, I told you very clearly, this is the C5 and the C6 and C7, and from there you can clearly appreciate that there is a nerve coming from here. This is the long thoracic nerve. And if this long thoracic nerve is injured, it is leading to what, guys? Winging of scapula. Injury to long thoracic nerve it will lead to what, guys? Winging of scapula. Okay. And then not only this, I want you to remember like other concepts from here. Suppose if there is an injury to upper trunk, if this upper trunk is damaged, injury to upper trunk will lead to Erb's paralysis, Erb's palsy, and in Erb's palsy, the very famous one, the sign is actually the policeman tip hand, or else it is also known as the porter's tip hand, or else it is also known as what, guys? The policeman tip hand, है ना? Waiter's tip hand. So the policeman tip hand or the porter's tip hand or the waiter's tip hand, okay, the waiter's tip hand, it's actually the sign of Erb's paralysis, okay. And not only that, you also have to remember that, yes, what is going to happen at each and every point. Number one, what is going to happen at the arm यानी मतलब है ना shoulder joint पर यहाँ पर क्या होगा, तो what is going to happen, the arm will be actually adducted. The person will not be able to abduct the arm. He is not going to take the arm away from here. So the arm will be adducted and it is medially rotated. Then after the arm, the next thing is elbow. The elbow will be flexed or extended. It will be extended there. And then what about the forearm, sir? The forearm will be supinated or pronated? Remember, it will be pronated. And finally, the fingers are actually flexed. So arm will be adducted and medially rotated. Elbow will be extended here. The forearm will be pronated. And then remember, the fingers are flexed. That is completely giving the appearance of a policeman's tip hand or waiter's tip hand. Okay. Then the next thing is actually about the injury to lower trunk. If this lower trunk is damaged here, अगर ये lower trunk damage होगा, then what is going to happen? It will lead to Klumpke's paralysis. And what is the sign of Klumpke's paralysis? The sign of Klumpke's paralysis will be claw hand. The sign of Klumpke's paralysis will be what, guys? The claw hand. In claw hand, I want you to concentrate on MCP, the metacarpophalangeal joint. Metacarpophalangeal joint, between the metacarpals and the phalanges, this metacarpophalangeal joint will be hyperextended. And then this interphalangeal joint here, this one will be the flexed, guys. So you can also do along with me there, guys. आप भी एक बार try कीजिए, making the claw hand. Metacarpophalangeal joint here, this will be hyperextended, and then the interphalangeal joint will be actually flexed. The metacarpophalangeal joint will be hyperextended, and interphalangeal joint will be flexed like this. It is flexed. Perfect. So this is known as what? Klumpke's paralysis. And in this Klumpke's paralysis, what is this hand, sir? What is the sign here? That is claw hand. इसको हम कहते हैं claw hand, sir. So injury to long thoracic nerve will lead to winging of scapula. Injury to upper trunk will lead to what, sir? Earth paralysis. Injury to lower trunk will lead to what, guys? Klumpke's paralysis. ठीक है ना? Abhishek Verma is asking, sir, how to differentiate between the partial claw hand and the hand of benediction? Partial claw hand, yes, in the partial claw hand, the nerve which is involved will be the ulnar nerve, and ulnar nerve, यहाँ पर क्या होगा, sir? Only these fingers will be flexed here, like this. This is how the partial claw hand will look like. Whereas in the hand of benediction, yes, this will be normal, absolutely normal. You can easily differentiate that one, no? Partial claw hand में तो ulnar nerve involved होगा, ulnar nerve involved, and only this side of the hand will be involved here. It will be something like this here. Whereas in hand of benediction, what is going to happen there? These fingers are absolutely normal. The median nerve will be involved. So in that, what you have to do is you have to actually ask the patient to make a fist. Normally तो उसका हाथ normal होगा, hand will be normal. But what you have to do is, yes, you have to actually ask the patient to make a fist. And when he's trying to make a fist, right now you and me, we are like normal people. हम लोग तो आराम से we can make a fist like this here. Yes, when you ask the patient to make a fist here, at that time what is going to happen? This is normal here, तो ये तो अच्छे से flex हो जाएगा, but this is not going to get flexed here because median nerve is involved. When median nerve is involved, all the 5 muscles of hand will be involved. That is your 3 thenar except adductor pollicis and the 2 lumbricals, the first and second lumbrical. So these are gone here, so this will not be flexed here, guys. So normally the hand will be okay, but when you ask the patient to flex or make a fist, yes, only this side will be flexed here and this will be remaining like this here, guys. Next one, guys. Now after this, the next condition here that we are going to see here. The next condition or the next concept that we are going to see here is this one here. So muscles involved in the lurching gait. So basically, yes, basically what I am trying to tell you here is that basically मैं आपको क्या बताना चाह रहा हूँ यहाँ पर ना, what I am trying to tell you is, please keep in mind, yes, nowadays they are actually testing about the partial claw hand and the complete claw hand and all the nerves involved in these conditions and all. They are testing on this one, guys. So please try to recall all these concepts like just before the exam. Why? Because in the last exam, they have given a image based question of partial claw hand. Yes, the partial claw hand, the nerve involved will be the ulnar nerve, sir. Okay. Next one, another like hot favorite thing of your MC examiner. Yes, another hot favorite thing of the MC examiner here is about the muscles which are attached to the femur. Now, muscles involved in the lurching gait are inserted at. So let me first of all tell you in detail about the muscles getting inserted here, guys. So if this is the upper end of the femur, in the upper end of the femur, remember this one here will be the greater trochanter. Greater trochanter. And this one here will be actually the lesser trochanter. Lesser trochanter. And apart from that, yes, you will also have a tuberosity here, and this tuberosity is referred to as the gluteal tuberosity, guys. Gluteal tuberosity. So there is a greater trochanter, and then there is a lesser trochanter, and then there is a tuberosity, and that tuberosity will be the gluteal tuberosity. Okay. Now remember the muscle that will be inserting onto the greater trochanter. The muscle getting inserted onto the greater trochanter over here, this one here will be the gluteus medius muscle and then the gluteus minimus muscle. So these two muscles are actually inserted onto the greater trochanter, and this was actually tested here in your exam. And what is the muscle getting inserted onto the gluteal tuberosity here? That will be the gluteus maximus muscle. Gluteus maximus muscle. And on the lesser trochanter, which was asked last year in the MC exam, the muscle that is getting inserted onto the lesser trochanter will be the psoas major muscle, and along with the psoas major muscle, there will be iliacus muscle, guys. Iliacus muscle. Okay? So it is also referred combinedly as iliopsoas, psoas major muscle and the iliacus muscle. Okay? So gluteus maximus muscle will be inserted onto the tuberosity, that is gluteal tuberosity. Medius and minimus will be inserted onto the greater trochanter, and then the vas major and iliacus at the lesser trochanter. First you learn this, aram se. Now along with this you have to also remember like what is the nerve supply. Gluteus maximus will be supplied by inferior gluteal nerve, whereas gluteus medius and minimus, these two will be supplied by superior gluteal nerve. है ना? Gluteus maximus will be supplied by inferior gluteal nerve, whereas medius and minimus, those two will be supplied by the superior gluteal nerve. And now let us come to the clinical aspect here. When this superior gluteal nerve will be injured, when there is an injury to the superior gluteal nerve here, then what is going to happen? These muscles are paralyzed. And when these muscles are paralyzed, the person will not be able to walk. Yes. When this muscle is paralyzed here, or the person will not be able to walk properly there, guys. So therefore, the person will be walking with like, his entire body lurching on one side. So it'll be like bending the body on one side and then walking. So that type of gait is actually known as what, guys? Lurching gait. इसको हम कहते हैं lurching gait, sir. So in lurching gait, what are the muscles which is involved here? Gluteus medius and minimus. And what is the nerve which will be involved, guys? That is the superior gluteal nerve. And those muscles are actually inserting onto the greater trochanter here. Hope the concept is very clear. So you have to remember where is the muscle attached, which muscle is attached, and you have to remember about their nerve supply, and just you have to also remember about their actions. So gluteus medius and minimus, these two are actually helping in what? They're actually helping in abduction at the hip joint. They're actually helping in what? Abduction at the hip joint. Whereas maximus will be actually helping in extension at the hip joint. So therefore, my dear friends, yes, what is this sign? What is this type of gait known as a lurching gait? And what is the sign which is actually positive in this one? That is your Trendelenburg sign is actually positive, guys. So muscle which is involved in lurching gait will be nothing but gluteus medius and minimus. Gluteus medius and minimus. Okay. And remember, the gluteus medius and minimus, they are actually attached at the greater trochanter. So therefore, the answer for this question will be the A. That will be attached at A. ठीक है? Yes, Abhishek Verma, in Trendelenburg gait, the nerve which is involved will be the superior gluteal nerve supplying to medius and minimus. So यहाँ पर medius and minimus attached होगा at A, greater trochanter. So at A, what is going to happen? Medius and minimus. Lesser trochanter is B here, iliacus and vas major, which was given last year. Okay, and then C here, gluteal tuberosity. The muscle attached will be the gluteus maximus muscle. And D here is actually the ischial tuberosity. You all know very well the hip bone will have like three parts. The hip bone will actually have like three parts, the ilium, ischium and the pubis. So the part which is present below here, this is nothing but the ischial tuberosity, and ischial tuberosity is the one where the hamstring muscles will be attached. Okay, and even the adductor magnus muscle will be attached. So that is not a thing which has to be discussed here in the lurching gait fell apart, sir. So my main intention, yes, my main intention here in this question here, my main intention was I have completed like many concepts at one place here. Attachments at the upper end of the femur, all the muscles which are attached at the upper end of the femur, and those muscles and their nerve supply and action, that is also done. And at the same time, the clinical condition, that is lurching gait, and at the same time, Trendelenburg sign. So guys, I am telling you, like this session is like very well planned session for all the important topics that you must revise before going to the exam. And I have concised it in such a way that मैंने उसको ना इतना सिंपल वे में इसको कंसाइज कर दिया है कि in one question itself I am trying to cover like all the aspects, everything in this one here, guys. The muscle, the nerve supply, अगर injury होगा तो क्या होगा, what will happen with the injuries and all those things, and along with that attachment to the upper end of the femur, everything has been done here, guys. ठीक है? Next one here. Let us go to the next concept here. Oh, identify the arrow marked joint in the given image. Please write down. I hope you're having your pen and paper along with you. One question definitely on 4th June 2022 from joints wala topic, sir. One question definitely in your June exam from the joints wala topic, sir. Joint pakka ek sawal pakka aayega, sir. Now before telling you about that joint, I'll tell you one thing here. Whenever you learn about types of joints, remember the types of joints, there will be like three types of joints. One will be the fibrous joint. One will be the fibrous joint, sir, which is immobile joint. The fibrous joint is actually the immobile joint, guys. है ना? And number 2, that will be the cartilaginous joint. Cartilaginous joint. And number 3, there will be the mobile joint, that is the synovial joint, sir. So the fibrous and then cartilaginous and then the synovial joint. First, what you do is have a clarity, have a clear idea in your mind, crystal clear idea in your mind that the joints are actually divided into how many categories, guys? It is divided into how many? 3 categories. The fibrous joint and the cartilaginous joint and the synovial joint, guys. Now let us see the further sub classification or subtypes of joints there. Fibrous joints will be in turn divided into 3 categories here. Number 1, the joint between the cranial bones, and between the cranial bones it will be sutures. And sutures are obviously immobile. Then after that, my dear friend, after the sutures, the next one here will be the joint between the tooth and the gum here. And between the tooth and the gum, that is your gum fosses. Gum fosses. And the third one will be actually the syndesmosis. Syndesmosis. That is actually a joint between the two bones with the help of like interosseous membrane. There will be interosseous membrane joining the two bones there. That is nothing but syndesmosis. And you got to remember one of the example of that one, that is your middle radial knot joint here. The middle radial knot joint here, and then inferior tibiofibular joint. Tibia and fibula ke beech mein inferior tibiofibular joint. So these two examples you have to remember for syndesmosis, guys. And the cartilaginous joints are again divided into 2 categories. One will be the primary, another one is the secondary cartilaginous joint. First, remember the another name of this one. The primary is also known as synchondrosis. And this is extremely important nowadays, guys, the cartilaginous joint. Why? Because they're asking many questions, many times they're asking. Okay, now almost every time they're repeating in the MCA exam about the cartilaginous joint. The first, you remember the another name there. The primary cartilaginous joint is known as what? Synchondrosis. And then secondary cartilaginous joint, it is also known as what here, sir? Symphysis. इसको symphysis भी कहते हैं. Now when you have to remember the examples, remember the examples of symphysis, the secondary cartilaginous joint, all the midline joints in your body, all the midline joints in your body will be the examples of symphysis. So just remember one golden rule there. The golden rule here is that the midline joints are nothing but your symphysis, guys. And synovial joint, nothing but all the mobile joints, like it includes all those things like, the ball and socket joint, hinge joint, and then you also have that condylar joint, bicondylar joint, the plane, pivot, all those joints comes under the synovial category. So this is the simple way how you have to remember, guys. Mohammed Rayan, gomphosis will be between the tooth and the socket. Between the tooth and the socket, gomphosis. Yes. Now, welcome to